We are just taking a minute to set this glitch. Okay, just bear with us. A very good afternoon, everyone. It is with great honor and pleasure to welcome you all to this 26th Pediatric TB Eco Clinic, which is being run in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. The Eco Clinic is a dynamic platform for case-based clinical discussions and dissemination of knowledge and bringing together all experts across the country for managing tuberculosis among children. I extend a heartfelt welcome to the directors and representatives from NIRT, NTI, state TB officers, directors of STDCs, esteemed faculty members from various medical colleges, district TB officers, medical officers, pediatric TB specialists, and all healthcare professionals participating in today's session. Today, Dr. Shobhini and Dr. Sanjay Mattu are busy in a meeting in the ministry, so they won't be able to join today's session. Now, please let me introduce the faculty from NITRD. I am Dr. Tulika Dhingra, Specialist Pediatrics at NITRD, and I will be moderating today's session. With me is Dr. Neeta Singla, Head of Department of Epidemiology, NITRD, and also Nodal Officer for Eco Clinics. To my right is Dr. Alok Yadav, CMO, NFSG, and Pediatrician at NITRD. Dr. Upasana will join us soon in the session, and she will be speaking to us for the inaugural address. We will begin the session, and we will pause it for a minute when Dr. Upasana is able to join for the inaugural address. Today's presenting team is Department of Pediatrics, AIIMS Raipur. The team is led by Dr. Atul Jindal, Head of the Department of Pediatrics at AIIMS Raipur. The case presenter is Dr. Santosh Navi, Senior Resident, Department of Pediatric Critical Care, Department of Pediatrics at AIIMS Raipur, and the case expert is Dr. Shubham Verma, Assistant Professor, Department of Pediatrics at AIIMS Raipur. So let's start with today's case discussion. Over to you, Dr. Santosh. Dr. Santosh, please start sharing your screen.
Yes. I'm just sharing the slides, ma'am.
Sure.
Good afternoon, everyone. Today we will be seeing an interesting case of uh, tubercular meningitis. So beyond hydrocephalus, this child had all the spectrum of complications what we can see in tubercular meningitis. It was a challenging case to diagnose and manage. So objectives of today's presentation are: when to suspect CNS tuberculosis in a pediatric patient presenting with acute encephalitis syndrome, and decision making and management of CNS tuberculosis. We had Master in, a 3-year-old boy hailing from Raipur. Informant was father. He presented with chief complaints of fever for 7 days, abnormal body movements uh, abnormal body movements 3 episodes, and altered sensorium for 2 days. Date of presentation was 15th of June 2026. He stayed in our hospital for a duration of 26 days. Coming to history of presenting illness, father gave a history of fever for duration of 7 days, which was undocumented, intermittent, no diurnal variations, relieved with medication, not associated with any rash. On day 3 of illness, parents noticed abnormal body movements in the form of bilateral tonic-clonic movements lasting 1 to 2 minutes with post-ictal drowsiness. Over the course of next 3 to 4 days, child had 2 to 3 episodes of such episodes. Parents also complaint of altered sensorium in the form of increased lethargy, opening eyes only to the stimulation, no verbal response, not interacting with parents, not indicating any hunger needs. On negative history, there was a history of no gaining weight for duration of last 2 months. There was no history of any cranial nerve deficits, no history of any paucity of movements, no history of twisting postures, no history of breathing difficulty, no abdominal distension or masses elsewhere in the body. Yellowish discoloration of the body was not there, no bleeding manifestation, no history of any ear discharge, no history of any recurrent infections, no history of contact with tuberculosis. On day 8 of illness, child presented to the AIMS Raipur. At presentation to the pediatric emergency in our institute, initial impression was unstable, life-threatening. In the form of child was appearing dull, work of breathing was abnormal, circulation was normal. In the initial assessment, airway was maintainable. However, the child was bradypneic with a respiratory rate of 22 cycles per minute. Efforts were poor. On auscultation, there was air entry was equal on both sides. Saturations was 100% on room air. On circulatory part, there was a tachycardia of 180 beats per minute. Color was normal, periperies were warm, central and peripheral pulses were good, CFT was 4 seconds, blood pressure was 102 by 75 millimeters of mercury. On disability component, child has a GCS of E2, V2 and M4, which was corresponding to 8 by 15. Pupils were TMM equally reactive to light. There was no seizure, posturing or paralysis at the time of presentation with a GRBS of 100 milligram per deciliter. He had a temperature of 98.6. It was classified as primary brain dysfunction. So on further history, there was no history of any previous hospital admission. There was no history of any previous such illnesses in the past. He was a firstborn to non-consanguineously married couple. There was no significant family history of any similar illness in the family members. Child was immunized for 3 years of age up to, developmentally attained all milestones appropriate for the age before this illness. On general physical examination to the ward, he had a vitals of heart rate of 175 beats per minute. Central and peripheral pulses were good. Blood pressure was 85 by 40 millimeters of mercury. Respiratory rate was 24 per minute. SpO2 was 99% on room air with a temperature of 37.8. Anthropometrically, he was weight was 10 kg, which was falling under -3 Z score. Length was 93 centimeter with a Z score of -1. Head circumference was 49 centimeter with less than -1 standard deviation. Head-to-toe examination showed hair texture and the color was normal. There was a pallor was present, hyperpigmented knuckles, platinacea was observed. There was no icterus, no lymphadenopathy, no other signs of nutritional deficiency. On systemic examination, there was a GCS of E3, V4, M5 and received to ICU. Cranial nerve examination, 3 mm equally reactive to lights. Fundus edema was there. Rest cranial nerve was within normal limit. On motor examination, there was hypertonia with a power of 3/5 in upper and lower limb. DTRs were 3+3+, that was brisk. Plantars were upgoing. There was neck rigidity was present. Other systemic examination was essentially normal. Respiratory system, bilaterally air entry was equal, no added sounds. Per abdomen, soft and non-tender, no organomegaly. Cardiovascular wise, S1, S2 heard and no murmurs. Coming to the database, we had a 3-year-old boy, developmentally normal, immunized for the age, firstborn to non-consanguineously married couple, presenting with acute febrile illness of 7 days, presenting with seizures and altered sensorium, signs of meningeal irritation in the form of neck rigidity, with features of raised intracranial pressure in the form of brisk DTRs and papilledema, with a moderate acute malnutrition, with anemia, probably nutritional.
Dr. Santosh, we'll just pause here. Just a second. I would just like to open the case here for questions. We have completed the history and the examination, and the national expert for today's session is Dr. S.K. Kabra, who's consultant pediatrics at Indraprastha Apollo Hospital. So, sir, are there any questions from your end if you want to ask the team?
Yeah, no major questions, but when you are presenting the database, specify that there was no weight gain for last 2 months and then subsequently acute illness or deterioration for last 7 days. This is just a small comment because it will give a clear idea that what we are dealing with, whether it is acute problem or it is ongoing for some time.
Thanks.
Thanks. Any other questions from the audience up till now? Okay, if there are no, Dr. Alok has a comment to make.
I just want to know, is there child is immunized as per the national immunization schedule or taking these vaccination from outside? Is there any BCG scar mark is present or any contact history of TB is also present in the family?
No history of contact with tuberculosis, sir. They had immunized according to the NIH schedule, and BCG scar was present, sir.
Okay. Any other question from the audience?
And whether there was any history of the measles, mumps, rubella that can cause the immunity to go down and the patient may have the TB.
No, sir. There was no any history of previous hospitalization, no history of any previous illnesses which required hospital care.
Okay, thank you.
How many members in the family? Little more about the family, please.
He was a firstborn to non-consanguineously married couple, ma'am. Father was a clerk and mother is a housemaker.
No, how many members in the family? Because just to know the other social background.
It's a nuclear family, ma'am. Father, mother, and the current child.
Okay. And anybody else who are visiting, like grandparents, anybody had history of either cough or anything suggestive of tuberculosis? Many a times parents may not have any history of tuberculosis. So in the extended family, any other history, I think that is going to be very important.
As per the father's information from history on history evaluation, there was no history suggestive of in the grandfather or a grandmother. There was no history of any feature suggestive of contact history with tuberculosis.
Okay, yeah, thank you.
Yes.
So if there are no questions, I would just like to highlight that the link for the pretest question has already been shared in the chat box. You all can attempt the pretest questionnaire. I think this is the best time before we go forward.
Any history of the vomiting in this child, basically the complaint of any vomiting episodes of?
Sir, history, fever, there was abnormal body movements and the altered sensorium. However, father gave key in between the episodes of abnormal body movements, child had 2 to 3 episodes of vomiting.
So these are the complaint by which the child is admitted in your side.
Yes, ma'am. Yes, sir. Yes, sir.
Okay, and previously any admission for this child of similar complaints in any
No,
other?
sir. No, so, sir. No issue of any previous hospital admission, sir.
So this child is coming first time for the above complaints in your
yes,
side.
Yes, sir.
Okay, please.
Should I continue, ma'am?
Yes.
Yes.
Please continue.
Let's analyze the case. So we have a 3-year-old boy coming with a fever, probably infectious process within 7 days without any initially systemic manifestation for an initial 2 days. After third day, he had abnormal body movements suggestive of seizures, followed by the altered sensorium with features of raised intracranial pressures. To localize into the system wise, probably appears to be child is having cortical involvement with the diffuse process. No feature suggestive of focal neurological deficit as of examination, and child also has a meningeal irritation, so in the form of neck rigidity. So based on the history, examination, and the case analysis, we can label it as a case of acute encephalitis syndrome with possible differential diagnosis of infectious and para-infectious and the intracranial space occupying lesion. In the infectious causes, we could consider bacterial causes like acute pyogenic meningitis, considering within 7 days, child is presenting with fever, altered sensorium, and abnormal body movements. Second possibility being the tubercular meningitis with complications, and the third possibility being the viral, probably HSV encephalitis. Uh, in the in the later part, rarely, second other possibilities would be para-infectious in the form of acute demyelinating encephalomyelitis, and the rare possibility of ICSOL was considered. Coming to the first day investigations on day 1 of presentation, child had a hemoglobin of 9.3, total leukocyte count of 10,200 with 81% of neutrophils and 14% of lymphocytes, with a platelet count of 4,87,000. Renal functions and the liver functions were essentially normal, with inflammatory marker of C-reactive protein was 43.6. Neuroimaging, which was done 1 day prior to our presentation to our institute, was suggestive of we can see that is a CMRF of the brain. The first A and B images are T2 weighted images, and the C and D images revealing non-communicating hydrocephalus with significant periventricular ooze with no areas of diffusion restriction on DWI image. In the same MRI, we can well appreciate extensive basal exudate in the sylvian fissure and the pre-pontine and peri-mesencephalic cisternae. You can see here there is extensive exudates in the sylvian fissure and the peri-mesencephalic cisternae. Based on history, examination, and the neuroimaging, we could pretty much sure we were dealing with tuberculous meningitis. Coming to the theory part, where there is a when to suspect tubercular meningitis, if there is an insidious onset of fever, neurological abnormality with or without headache or vomiting, poor feeding or weight loss, irritability or lethargy, seizures, confusion or coma, neck stiffness. Among these, our child had weight loss, not gaining weight for last 2 months, irritability, seizure, confusion, and neck stiffness. And subsequently, immediate investigations which are advocated for tubercular meningitis are neuroimaging, CSF study, and evaluate for TB elsewhere. In neuroimaging, any one of the neuroimaging features as like basal enhancement, hydrocephalus, infarcts, and tuberculomas are very much likely of suggestive of TBM. Here we have, in our case, basal enhancement and the non-communicating hydrocephalus. The CSF test, which will indicate TBM, are white blood cells of 10 to 500, that is moderate phagocytosis with a lymphocytic predominance, protein of more than 1 gram per liter, glucose of less than 2.2 millimole per liter, or CSF to blood glucose ratio of less than 0.5. And the other evaluations required are to look for the possibility of tuberculosis in other regions, like look for the pulmonary tuberculosis, do a chest x-ray, lymph node, and the CT of the abdomen. Based on this algorithm, we may end up in 3 clinical scenarios based on CSF testing and the neuroimagical results. First possibility would be CSF is positive for Mycobacterium tuberculosis, gene expert, where we have to start the anti-tubercular therapy. Other possibility would be gene expert could be negative, but the AB smear would be negative, but neuroimaging consistent with TB in the form of basal excrete, hydrocephalus, tuberculomas, and the infarct. The other possibility would be microbiological investigations are negative along with the neuroimaging not consistent with TBM. In that case, we could reasonably exclude other causes of other possibilities like pyogenic meningitis and the parainfectious illness. So if there are no other possibilities which can explain the history, examination, the neuroimaging findings of the child, start ATT. And if the clinically condition of the child is critically ill and the clinically it appears to be child is having TBM, we can start the ATT. If the child is not critically ill, we can evaluate further for the possibility of TBM. In our case, based on history, acute encephalitis syndrome with features of raised ICP, neuroimaging suggestive of hydrocephalus, non-communicating, with basal exudates, we started the child on anti-tubercular therapy. On day 2, subsequently CSF reports were suggestive of tubercular meningitis. Coming to the course in the hospital stay, immediate at presentation emergency concerns of the child were GCS was less than 8, child was intubated and ventilated for airway protection. Because considering raised intracranial pressure, child was started on anti-raised ICP measures in the form of pseudoanalgesia and the hypertonic saline therapy. A presumptive TB based on the history, neuroimaging findings, anti-tubercular therapy was started along with the dexamethasone. Subsequently, the neuroimaging part, which was done, CT also done at the admission, showed the communicating hydrocephalus with periventricular ooze, and the CSF was suggestive of 12 total leukocyte count with 100% lymphocytes. CSF protein was 104 milligram per deciliter. CSF sugar was 46. CSF CBNAT was showing MTB, Mycobacterium tuberculosis was detected. Evaluation for the extra CNS TB was negative. Chest X-ray is normal. USG of abdomen was normal study. Fundus was not suggestive of any chorioretinitis. Subsequently, because considering communicating hydrocephalus with raised ICP, decision of CSF diversion was taken. Child underwent ventriculoperitoneal shunt. We can see in this CT, repeat CT, where the hydrocephalus has reduced in the size, and there is a we can differentiate gray and white matter differentiation here as compared to the previous CT. During the course of the hospital stay, child had multiple complications in the form of reduced urine output with hyponatremia with the sodium of 123, serum osmolality of 299. Diagnosis of SIDH was considered and child was managed with fluid restrictions. Child was continued on mechanical ventilation. Anti-raised ICP measures were continued with VP shunt in situ. Anti-tubercular therapy and dexamethasone were continued. However, on day 12, child had new onset clinical worsening in the form of status dystonicus. Features were hyperthermia. There was elevated CPK level to 894 with urine myoglobin was present. Here we can see in the video, child was having dystonic posturing on day 12, even on appropriate measures for anti-raised ICP, anti-tubercular therapy with adequate dosing, and dexamethasone. Repeat neuroimaging for new worsening was done with anti-dystonic measures were continued. This was the repeat neuroimaging. We can see there is a multiple infarct on the left lenticulostriatal area and the parieto-occipital area. Here the child was started on aspirin therapy. Subsequently, child was continued on ATT, dexamethasone, and aspirin. So during the PICU stay, extubations, multiple extubations failure were noticed, and because of the laryngeal dystonia. Because of the laryngeal dystonia, child was underwent tracheostomy insertion on day 12. With continuing ATT, dexamethasone, and antidystonic medications were continued. Child was weaned off ventilation, and the child was continued on TPs and the shifted to ward subsequently. Finally, we planned to decannulate in the follow-up. Steroids planned for 4 weeks and taper off in the next 2 weeks. ATT was continued and aspirin was continued. Review of the case: it was a tubercular meningitis with complication, with acute complications of seizures, raised HCP, and hydrocephalus, with other complications of SIDH, status dystonia, arterial infarct, and the multiple extubation failures during the hospital stay because of the laryngeal dystonia and the hypertonia. However, with adequate measures, child was discharged on tracheostomy tube with GCS of E4, VT, and M5.
We'll take a pause here, Dr. Santosh. We'll take the case for discussion. Sir, may I request you to, they have mentioned, the team has mentioned about the diagnosis of TBM here in this case. They have the IIT and the CTD guidelines also similarly mention about criterion-based diagnosis. So anything that you would like to highlight here, so that because we often face difficulties in diagnosing TBM because getting a sample, CSF sample, is difficult. First, please.
Yes, thank you. You rightly pointed out that it is very difficult and challenging to make a microbiologically confirmed CNS tuberculosis because of low sensitivity of the available tests on CSF. But they were fortunate enough to have a positive. And in such a situation, and you can follow any algorithm because of diagnostic issues. There are multiple algorithms, but all are based on the clinical features along with suggestive imaging, contact history, and other things, so that you can make a diagnosis of tuberculosis, CNS TB. For to emphasize that all extrapulmonary TB, EPTB, the sensitivity of the test is low. That's why we try all the methods available, whether it is the pulmonary TB, whether there is a lymph node TB, lymph node enlargement or pulmonary lesion. We try to document those samples, try to get those obtained and document the TB. And other thing, just a minor point, was that they suggested the report he presented that CB0 was positive, detected Mycobacterium tuberculosis. But now with a universal DST, we should also mention about whether the rifampicin resistant detected or not detected. Otherwise, it was a well worked up, well presented case. Thank you very much.
Thank you, sir. Are there any questions from the audience as well?
Yeah, I just have a comment. That is, one is, I think the postgraduate did not mention about the rifampicin resistance. I think that is very important. And for the postgraduates, when you put a final diagnosis here, it cannot be just TB meningitis. It is a bacteriologically confirmed, probably it is a drug sensitive tubercular meningitis. Instead of with complications, probably can we add it as stage 3?
Yes, ma'am. It was a microbiologically proven rifampicin sensitive tubercular meningitis, stage 3 according to the MRC stage.
And stage 3 along with the moderate acute malnutrition and
Yes.
anemia. I think it's very important for the postgraduates to give a complete diagnosis. That is one comment. And the second comment is the indication for aspirin in a child, we know that this child has TB meningitis and infarcts are known to be there. And I just want to know from others the indication for aspirin in this child.
Yes, ma'am. Can I take up the question, ma'am? On day 12, ma'am, our child has a knee worsening in the form of status dystonia and the some amount of fluctuations in the autonomic heart rate and the blood pressures with features of raised ICP also. We could not attribute to the initial illness. So we did repeat a neuroimaging CT, which was suggestive of arterial infarct on the lenticulostrial part of the basal ganglia portion in the on the left side. Considering the second week of illness and the new worsening, we thought of covering adding the anti-inflammatory host directed therapy in the form of aspirin.
So, Dr.
However,
Gupika, can I come? Can I come?
Please, please.
Yeah, there was a definite deterioration despite steroids and anti-TB drug. And the reasons may be that one is there is a uh, vasculitis causing infarction. And second thing is there may be paradoxical reaction with the anti-TB drugs. Generally happens between 2 weeks to 8 weeks or 6 weeks. And as far as aspirin is concerned, the treating unit might have decided because of the vasculitis and to prevent further occlusion due to thrombosis. Some units use it, but it is not an established therapy. It may be, and neither there is a good documented RCTs, but some units use as a antiplatelet role of the aspirin. So generally the treatment would be supportive care and it would improve if it is a paradoxical reaction within a week or two with supportive care. Thank you.
Thank you.
Hello.
Can I have one more question, please?
Okay. So in this child, at the presentation, the child was having just fever of 7 days, but there were advanced features of the altered sensorium, toxicologic movements, hydrocephalus, tuberculosis, and others. Which means the child was having the ill health earlier also, so the parents could not recognize. And since you are telling that there was no history of this TB in the family, so whether the child got the infection from the other source, so we should be going for the reverse contact testing in these type of the cases. The child was having CB-net positive. Whether you had taste the results of the first line and second line LP also or not, and then whether we should go for this the screening of the spine or ruling out the early complications like radiculitis, arachnoiditis, radiculomyelopathy, syngomyelia, or not, since the child was having the other dystonia and other complications, and whether the persistence of the hydrocephalus with the adequate therapy was because of the obstruction or because of the paradoxical reaction. So how to rule out that?
Yes, sir. Definitely, sir. It was very interesting key as considering only 7 days history with presenting with such a stage 3 CNS tuberculosis. We did do reverse tracing. We did a chest X-ray of parents, which was negative for the pulmonary tuberculosis. And considering we know that it is a subacute illness presenting with CNS TB, it was a short history compared to the typical case. Then coming to the other evaluation for the other sites for the tuberculosis, we did chest X-ray to rule out the pulmonary, and there was no any lymph node enlargement to suggest, and we did ultrasound abdomen to rule out the any and the granulomas in the liver and the spleen, and we did do a spine X-ray, which was not suggestive of any destruction of the vertebra or the accumulation in the spinal part. Then third question was
the first line and second line LPA report testing?
Sir, as I earlier stated, CSF was positive for the Mycobacterium tuberculosis with rifampicin sensitive pattern. So we did not do the further testing for the drug sensitivity.
So any role of the intrathecal steroids of the anti-TB drugs, and
There are
whether you are
no,
using the
yes,
same
sir, there are no
anti-human or you are adding ethionamide also?
Currently there are no any guidelines to add any intrathecal medication, sir. Indicated therapies being only antitubercular therapy with corticosteroids. Initially IV followed by the oral for duration of 4 weeks, later tapering to 2 weeks. Other in different randomized control trials and the studies are looking into the other therapies which can act on host directed therapies in the form of interleukin 1 infliximab, adalimumab, and some centers are there are few indications for the host modifying drugs like thalidomide also. However, no guidelines are strongly recommending these adjuvant therapies as of now.
So in this patient, the CRP was raised. So whether you had given the concomitant antibiotics also?
First day one, we did start the as clinical history was suggestive of acute encephalitis syndrome. It is a broader spectrum diagnosis. We did consider before looking into a neuroimaging part. We did started to cover the pyogenic meningitis part. When we were sure on the neuroimaging part with extensive basal exudates with hydrocephalus, non-communicating hydrocephalus part, we did stop the antibiotics and continued on antitubercular therapy, sir.
Since sir has said that it is very difficult to prove the TB meningitis, so it will be prudent to start both antibiotics and anti-TB to avoid the complications or not?
Definitely, sir. Once we look into the algorithm part, it definitely says ki when we were not able to isolate the organism and the child is critically ill, it definitely have to start on ATT. If neuroimaging getting delayed, it is wiser to start antimicrobial therapy to cover the pyogenic meningitis part also. As at least in this child, history was only for 7 days.
Thank you.
Yes.
I have another comment. You said that CSF CBNAT Mycobacterium tuberculosis was detected and rifampicin sensitive, and further evaluation was not done. But when you go through the algorithm, once an MTB is detected and once you know that it is rifampicin sensitive, we always have to look for the INH monoresistance. We know that the INH monoresistance is very high. Even in Indian children, it's about 15 to 20% of them can have a INH monoresistance. At least if you don't go ahead with a first line LPA, we're very likely to miss INH monoresistance. So in fact, when you look at the NTEP algorithm, or what is called as the integrated algorithm for DRTB, so whenever an MTB is detected, then you have to look at whether the rifampicin sensitive or not. If there is a rifampicin resistance, of course, you will go towards the MDR-TB. If it is rifampicin sensitive, then always you have to send for LPA so that you will not miss INH resistance and later further resistance. Thank you.
Just want a small comment regarding, as sir asked why this patient, can we add the ethionamide basically? So ethionamide is a very good drug, but it is a second line drug, and in the first line drugs, the drugs pyrazinamide, INH, these are very good CNS penetrating drugs. So these act very good. So pyrazinamide, INH, then rifampicin, then ethionamide, these are very good drugs in the first line. If the child have drug resistance, then we can add the linezolid. There is one question regarding the linezolid and the ethionamide. So ethionamide is a second group drug, and ethionamide and cycloserine, they both drug have a good penetration of 50 to 100%. And then the linezolid, and if the meninges are inflamed, then we can add the amikacin and the streptomycin. So regarding the first line ATT drugs, they work well. So The duration of the tubercular meningitis is for 12 months, 2 months of intensive phase and 10 months of the continuation phase.
Would you like to give your comments on ruling out INH resistance in such a case? Dr. Kamra, sir?
Yes, yes. Thank you. So definitely, as I said, uh, one is that we should always try to send the culture of CSF, because even in the NTEP, there is a provision that all precious samples should be cultured. So we should do a MGIT culture on CSF. And as Madam suggested that we could have done a LPA, but LPA, because the possibacillary nature of the disease, once the culture is positive, then you can do a LPA to see if it is a INH sensitive or resistance. Second thing is regarding ethonamide. So, as someone also mentioned in the question in the chat box, that WHO has suggested 6 months of shorter duration for CNS tuberculosis, but it has not been included or incorporated in the National Tuberculosis Elimination Program, because the experts want that there should be some data generated locally, though it looks like a very good regime of shorter duration. That's why this ethonamide along with three other drugs are not being recommended for the treatment. As of now, we are having a longer treatment. And then again, the history. We generally we pick up the notes from the history. What is very clear that fever, dystonia, but this child is not well, because at 4 years of age we do not expect that there will be too much of a weight gain. But history clearly suggests that there was no weight gain. It means he was not doing well. So it is very. I re-emphasize that take a good history that will give a very clear picture about this thing. Thank you very much.
Thank you, sir. Thank you. Dr. Neeta Singha also has a question from the. It's a question more for general knowledge point of view, because we have few of DTOs who have joined. So I would like to know what are the things that should be the symptoms that should be looked for at the PHC level, from where the child is going to be referred. What are the criteria for referring the patient to a higher center?
Yes, ma'am. As we saw earlier in the algorithm part, we could see here that when to suspect a CNS tuberculosis. So when there is a history of fever for a subacute 7 to 10, 2 weeks of fever, followed by features suggestive of neurological involvement in the form of headache or vomiting, poor feeding or weight loss, irritability or lethargy, history of seizures or altered sensorium, neck stiffness, cranial nerve palsies, and hemiparesis. So, with the strong any history of any to contact with tuberculosis also adds to the history part. So, if any child coming with fever with these neurological abnormalities, we should always think of CNS tuberculosis in Indian scenario.
Of treatment for this case.
Duration of the treatment.
Sorry, sir. Can you please repeat?
I just want to ask, what is the duration of the treatment in the drug sensitive TB cases? In the TBM?
12 months, sir. 2 months of intensive phase therapy and followed by 10 months of continuation phase.
Just a small question regarding the hydrocephalus. How you manage the hydrocephalus in this child as the child develop SIADH? So can you explain? There is one question also.
Yes, sir. In this child, the child had hydrocephalus, communicating hydrocephalus presentation, along with the ventricular ooze with a significant raised intracranial pressure. Initially managed with medical therapy with 3% hypertonic saline and the pseudonalgesia part, as the child was already in a state of stage 3 CNS tuberculosis, we planned for surgical diversion of CSF in the form of ventriculoperitoneal shunt. Child underwent ventriculoperitoneal shunt on right side on day 1 of hospital. Subsequently, in the re-imaging, neuroimaging, hydrocephalus significantly reduced, and the yes, other CSF diversion techniques like EVD can also be used.
Okay. Is there any other question?
Yeah,
So, Dr. Santosh, you can continue with your didactic. We'll take the remaining questions later.
Thank you, Dr. Santosh, for the case presentation. I am Dr. Subham. I will be presenting the didactic part of this lecture.
Okay. Please carry on, Dr.
Okay. So global burden of tuberculosis is very high. It is 10.8 million each year, globally each year, with 2 to 5% who develop tubercular meningitis, and 1 to 2% of all active TB patients are have some kind of CNS involvement. And case fatality is very high in CNS tuberculosis. It is 15 to 40% despite the effective therapy. The reason why there is a very high mortality and morbidity, because it is very difficult to diagnose the tuberculosis, CNS tuberculosis in initial stage. Like, there are 3 stages as per MRC 1, 2, and 3, and most people we diagnose in either stage 2 or stage 3, and by the time they are in stage 2 and stage 3, there will be high mortality and morbidity. That's why being only 1 to 2% of 2 to 5% of cases which are tubercular meningitis, 15 to 14% mortality is there. So we will be discussing the pathogenesis of CNS tuberculosis, how it developed. So the primary focus is mostly the lung, from where it disseminates, and there is blood-borne spread, and it penetrates the blood-brain barrier. So there are 2 barriers. One is blood-brain barrier and one is blood CSF barrier. There are few mechanisms which are thought to be how the mycobacterium penetrate the blood-brain barrier and blood CSF barriers. One is with the macrophage is enter the blood-brain barrier. Second is there are some genes which causes the adhesion to the endothelium, and third part is with the actin filament and cytoskeletal changes in the blood-brain barrier, it enters the brain. In the brain, it forms a rich focus, which is a granuloma, and there are two theories by which the CNS tuberculosis get activated. One is by rich focus, and another is by the miliary dissemination. So initially, it was thought that only rich focus causes the CNS tuberculosis, but now both mechanism are thought to be causing. So there will be multiple. The main reason why CNS tuberculosis causing problem is there will be intense inflammatory reactions which will lead to meningeal congestion, edema, inflammation. There will be exudates which will block the cisterns and will cause obstructive and non-obstructive hydrocephalus. There will be brain parenchymal lesion as tuberculoma, and there will be inflammation in the small vessels which will cause vasculitis, thrombosis, and infarcts. And all this will lead to the increased raised cranial pressure, will lead to headache, vomiting, and other cranial nerve involvement, followed by coma and seizures. So, for the clinical features of tubercular meningitis, there is very variable symptoms which will child will present, and the fever will 20 to 70%, headache 25 to 70%, meningeal signs of meningeal irritation in 35 to 90%, lethargy, drowsiness 25 to 30%, vomiting 30 to 70%. So, more common is like vomiting, headache, and signs of meningeal irritation, and sometimes present with acute worsening with either development of hydrocephalus or with some secondary bacterial infection. So the spectrum of CNS tuberculosis are three. Like one will be meningeal involvement that will lead to leptomeningitis and hypertrophic pachymeningitis. In parenchyma, it could be TB severitis or TB vasculopathy. And in spine, it can lead to spinal tuberculoma, spinal meningitis, and Pott's spine. So for the complication of tubercular meningitis, it could be early as SIADH or DI, which are the leading to the metabolic component and leading to hyponatremia or hypernatremia, and it it can also lead to the severe salt wasting in late phases. Second part is hydrocephalus. Hydrocephalus develops early as within 3 to 6 weeks of the primary symptoms of tuberculosis. Even if some patient who had not developed hydrocephalus at the diagnosis may develop within 3 to 4 weeks of diagnosis to the hydrocephalus if there is no proper treatment received. Then another early complication is vasculitis that can lead to stroke, and there will be multiple involvement of multiple cranial nerve and symptoms will appear. In late phases of late complication of TBMs are, one is paradoxical reaction, which is due to immune reconstitution, and due to intense inflammation it will again further worsening. So normally paradoxical reaction occurs after 1 to 2 weeks of therapy, and with the initial improvement of the patient, the clinical improvement, there will be secondary worsening. So we always have to look for if there is any new hydrocephalus development or any secondary vasculitis or any the two common paradoxical reaction which are very dated are, one is spinal involvement arachnoiditis, and another is the optic nerve involvement, which is reversible, which is irreversible. Another rare complication is secondary moyamoya and could be secondary structural epilepsy. For the staging of tubercular meningitis, there are two commonly used. One is medical research counseling staging of tubercular meningitis. So stage 1 is non-specific symptoms, few or no clinical signs. Meningitis may be present and child is fully conscious and alert. So in here you can find other symptoms such as weight loss or not gaining weight and some lethargy. But there will be no major focus if you are not examining properly. And it is very difficult to clinically diagnose tubercular meningitis in stage 1. Stage 2, there will be signs of meningitis, drowsiness, lethargy, cranial nerve palsies. In stage 3, there will be severe clouding of consciousness, stupor or coma, convulsion, gross paresis or paralysis. So most of the tubercular meningitis cases we detect in stage 2 and stage 3 rather than in stage 1. That's why there is a poor prognosis of tubercular meningitis. Like we are identifying the disease late. There is also Polar by Vellore staging by Polar et al., which suggests stage 1 with normal sensorium and without any neurological deficit. Stage 2 will be normal sensorium with neurological deficit. Stage 3 will be altered sensorium with or without neurological deficit. And stage 4 will be deeply comatose with or without posturing. So this parallel staging of TBM with hydrocephalus is mostly important for how we are treating the hydrocephalus. If we can manage in stage 1 and 2, we generally try to manage with medical therapy. In stage 3 and 4, we try to go for some intervention like extraventricular drainage or ventriculoperitoneal shunt. So recommended doses for first line tuberculosis, rifampicin 10 to 20 milligram per kg per day, average is 15. For isoniazid 7 to 15, average is 10. Pyrazinamide 30 to 40, average is 35. Ethambutol 20. And for children, it is recommended to use higher range of isoniazid for more clinical benefit. So there is also host-directed therapies which are used in tubercular meningitis, because as we have seen in pathophysiology, there is intense inflammatory reaction which is causing multiple cranial nerve palsy, vasculitis, and basal episode leading to hydrocephalus. So there are studies on steroids, aspirin, TNF alpha blockers, and IL-1 antagonists. So there is only studies on steroid which are suggesting decrease in mortality and clinical improvement. The meta-analysis on aspirin does not have provided any extra benefit to reduce the mortality or reduce the infarcts. And there are clinical trials on TNF, infliximab and anakinra, to try for the prevention of paradoxical reactions. So cerebral infarction occurs in 25 to 70% of TBM cases and associated with two-fold increase in mortality. So aspirin is used as anti-inflammatory and anti-thrombotic property, and dose is 3 to 5 milligram per kg per day. That is low dose aspirin. As of WHO 2022 guideline, it is not recommended prophylactic aspirin in all TBM cases, and it should be used on conditional case-to-case basis for infarct or vasculitis. And currently there is no clear evidence for use of aspirin in tubercular meningitis, prophylactic or as treatment. So I was talking about the late complication, which is one was paradoxical reaction in which there is a host-directed therapy. Like we start corticosteroid at the start of treatment to prevent the inflammation after the starting of ATT. But even if the patient is unresponsive to the corticosteroid for preventing inflammation and any paradoxical reaction occurs, the most one common complication is optochiasmatic electronditis. So to prevent that, we can use host-directed therapy as infliximab or adalimumab or and now we will discuss the role of surgery in tubercular meningitis. So there are both type of hydrocephalus that can develop in tubercular meningitis, communicating and non-communicating. For communicating hydrocephalus, basal episodes are the main pathophysiology. For non-communicating, any tuberculoma or obstructing third or fourth ventricle can lead to non-communicating hydrocephalus. So non-communicating will need immediate surgical intervention as there is risk of herniation. For communicating, we can give trial of medical therapies such as for the raised ICP, we can use the 3% NS or mannitol. And benefit of shunting should be weighted against the risk of complication. So there is 30% risk of shunt infection and there is chances of blockage. So we should outweigh the risk versus benefit. So parallel stage 1 and 2, we can try for medical management for 1 week. If there is no response, we should go for the VP shunt or EVD, and if there is a response, we can continue ATT. But for stage 3 and 4, we should go for, or any obstructive hydrocephalus, we should go for the VP shunt. External ventricular drain in parallel stage 4 or GCS less than 3 M3, and if any raised ICP which can be decreased on EVD, then we can go for the VP shunt, which is a major surgical procedure. And EVD we can do on bedside also. And if we need drainage of the tubercular abscess, as in abscess the ATT does not penetrate, so we can go for neurosurgical drainage. Thank you for listening. If there are any question, we are.
Yes, thank you, Dr. Shubhu. And now Dr. Alok will. Are there any questions from the audience?
Hello.
Yes.
I'm Dr. Jayakishan.
Yes. Sir, आपकी आवाज
अब ठीक है?
Yes, sir. Yes, sir.
Okay. So the rich focus is a known entity where the tubercle focus, the hematogenous subtype settles into meninges. Okay. So this is primary TB or the secondary TB. One. Every time this is a primary TB. So how to diagnose this primary TB at the early stage so that patient do not go into this full-fledged TBM. Okay, 1. 2. Once patient is having the obstructive type of this hydrocephalus, then any role of this surgical intervention at the site of the obstruction, lower down also, the spinal canal or the radicals?
Any other question, sir?
Yes, nothing.
Okay.
Please clear the
So, as
query.
for the obstructive hydrocephalus, we should go for extraventricular drain or VP shunt to remove obstruction, as it will not improve with just ATT, and it will cause there will be increased risk of raised ICP and herniation. And for
Okay.
the first question, as I told, it is very difficult to diagnose tubercular meningitis stage one, because it will be non-specific symptoms, and only there will be mild symptoms of meningitis, and child might have only history of weight loss and tubercular contact. I think.
No, reach focus. I'm
Pardon?
asking about the reach focus. That is a primary tuberculosis in case of the TB meningitis. The TB meningitis can spread into the post-primary from the reach focus also.
Yes, sir. Yes, sir.
So how to diagnose that reach focus?
Okay, sir. So,
Sir, sir, would you like to come in here? Dr. Kapra, sir.
Regarding this, whether it was a primary or secondary, that doesn't make a difference as far as treatment is concerned. And I am not expert, but I am not aware whether there is any modality to see subpile focus, because that will be very small, and I don't think any imaging will be able to identify it.
Okay. It's difficult to diagnose the reach focus. Okay. Agreed.
Yeah, Dr. Alok would summarize the case and also discuss the workflow. Kabra sir, I just wanted to discuss one matter. Like when we are in the field, I'm not a pediatrician, I'm more in the field. In the field, we see that most of the time the treatment is extended up to 2 years. If they keep on writing continuous same treatment, it's not only a pill burden on the patient, but it's a big financial burden on the program also, because we are paying them 1,000 rupees per month, and to process that 1,000 rupees, there's a lot of official formalities also. So these two things really bother us in the field.
Yeah, definitely. This is a concern that specifically this CNS tuberculosis and bone and joint tuberculosis, because the field people, they want to continue the treatment, continue same, and the because symptoms may not resolve 100%. There will be improvement, but there may be some deficit and other thing, and that is the reason why they continue. But there is no evidence to suggest that extending beyond 12 months of anti-TB drug will help in complete recovery. So that we should try to educate the people, including our doctors, that there is no point of extending same drug beyond 12 months unless you are considering that it is some drug-resistant TB, and for that you need to investigate. Same thing happens with the extrapulmonary TB in form of a bone and joint, because there is some deficit, and that's why the physician who is treating, he feels that yes, the child has not recovered completely, and that's why we continue. So our aim is to reduce the duration rather than increase, and there is no evidence that if regime of DSTB extended beyond 12 months will have any benefit as far as complete resolution of symptoms are concerned. Thank you.
Sir, so in case of the TBM, if there are complications decrease, the child will persist with the symptoms, neurocognitive symptoms also, problems also. So in this type of the scenario, whether there is a role of the PET-CT to see the activity in the CNS of the TB to continue with the anti-TB or not?
So people have tried to see PET-CT to see the delayed clearance of the this lesion on PET-CT, but it doesn't correlate very well with the activity. So it's very difficult to say that PET-CT will definitely give idea regarding activity of the disease. Rather, it will increase the radiation. That's why, as of now, it's not recommended.
Okay.
Yeah, thank you, sir. So we right now just two slides we will just discuss regarding the protocol, which is the standard treatment workflow of ICMR and NTP. Sorry. Okay. So these are the standard workflow guidelines. So when to suspect, these are the guidelines because in this group there are pediatricians and DTOs and medical officers also, as ma'am already discussed. So when you suspect the tubercular meningitis in the children, so previously we had already discussed in the case that fever with one of the following points regarding the headache. Child is having headache, vomiting, any episode of the seizure, irritability, letharginess, drowsiness, and loss of function. That is any recent onset deviation of the eye, mouth, or weakness of any arm, leg, or any altered palpitation, myalgia, anorexia, and weight loss. So these are some of the symptoms if there is with the fever, associated fever. Symptoms are usually of 5 to 7 days and insidious in onset, and also there is any history of the past history of the TB in the last 2 years should also be considered. So is the examination in these cases basically. So assessment of the sensorium, if anterior, check the anterior frontally, if this is full. Meningeal irritation, sign of the meningeal irritation, just like a neck stiffness, Kerning sign, and Brodsky signs. Eye examination, if there is any papilledema, choroid tubercle, and optic atrophy, any cranial nerve involvement, and motor systemic examination like flexor, plantar flexors, and power tone of the limbs. Also find out any peripheral lymph node in the children and chest examination to find out the pulmonary involvement also. So what are the investigation we can plan in the children? First is CBC and CSF examination is very important to find out the TB meningitis, viral bacterial meningitis, or any other meningitis. So in the CSF examination, we do the cell counts. Mainly in the cell count, we find lymphocytic predominant. Sugar is protein and NAT and culture and bacterial culture. So in the CSF count, we found protein is more 1 to 5 gram per liter. Sugar is less than 0.5 of the blood sugar level, and NAT to find out the drug sensitive drug resistance, and cultures for bacterial culture to rule out the bacterial meningitis, HIV, CT scan, chest X-ray, gastric lavage, induced sputum in the patient where chest X-ray is found abnormal. So these are some basic investigation. There are some desirable investigation if we found out the CNS, then MRI brain with contrast when CT head is not contributory. There are other optional in the diagnosis is CSF cryptococcal antigen and CT abdomen to look for any other lesions. CT, so hydrocephalus, thick basal exudate, and tuberculoma defined. So this is the diagnostic algorithm. So immediate investigation, CBC, HIV, CCT head, CSF, cell count, including differential, CSF, sugar level, protein, NAT, bacterial culture, chest X-ray. So there are three criteria. Criteria one is greater than 3 of the following 5 days of symptoms as above. Total counts less than 15,000. CSF WBC count is 10 to 15 cells. CSF sugar is less than 50% of the blood sugar. And CSF is mainly lymphocytic. Neuroimaging finding is basal exudate, hydrocephalus, infarct, and tuberculoma. Criteria 2 is at least 2 of the following 3 risk factors are present: HIV, severe acute malnutrition, recent contact with the TB infection. And criteria C is elsewhere of TB. So any two criteria are meet, then we can start the treatment. If two or more criteria is not meet, then we have to find some other thing. Continue investigation and management for partially treated bacterial meningitis. If not better, then we can plan for the repeat LPA after 48 to 72 hours. Expand search for TB elsewhere. Consider MRI if or done earlier. Revise the criteria 1, 2, 3 and see if greater than two criteria fulfilled. Plan to start the TB treatment. Next. So, output of it. So pre-review criteria 1, 2, 3 and if greater than two criteria fulfill, yes, then we can start the treatment. No, then does patient falling CSF glucose, dropping sensorium, does any new focal deficit is present, then we have to evaluate the child. So what is the treatment and how long the treatment duration? In the TB meningitis, as per the NTP guideline, the duration is of 12 months, 2 months of HRJD and 10 months of HRE. With pyridoxine, with corticosteroids. Corticosteroid we can give prednisolone or dexamethasone. Prednisolone is at the rate of 2 mg per kg per day for 4 weeks, then taper for over 4 weeks. And dexamethasone is 0.15 mg per kg per dose, or total dose is 0.60 mg per kg per day. Slow taper needed in some patients. Other supportive therapy, care of unconscious child, nasogastric feeding if indicated. If child is having hydrocephalus, then we can plan to add mannitol, hypertonic, saline, glycerol, acetazolamide. If child is having convulsion, then we can plan to add the anticonvulsant therapy, most preferably levetiracetam. Surgical therapy is if indicated. Most of these children should be treated at least district hospital or in the medical college. Early referral to medical college is always considered. When child is unresponsible child, rapid deteriorated, not diagnosis after initial evaluation, surgical treatment needed, or we are suspecting the drug-resistant meningitis in these children, and the child needs the ICU care. So these children should be referred to the medical college or higher center nearby. So this is the protocol as per the NTP guidelines. So this is the guidelines. So right now I am also summarizing the case. So this is the 3-year-old child which was presented to the AIMS Raipur with having fever from 7 days, altered body movement and altered sensorium. Fever is intermittent, non-documented, wide abnormal body movement is in the form of the uprolling of eyeball and having bilateral tonic-clonic seizure. Child is lethargic and not interesting with parents and having verbal response in the form of incomprehensive sound. As per the GCS of child is E2, V2 and M4. Child is immunized as per the national immunization schedule and achieve all the milestone as per the age. ECG mark is present. While the physical examination, the child is having tachycardia, anemia, increased respiratory rate with hyperpigmentation occurs. Child is having the sign of the meningeal irritation in the form of the neck rigidity, papilledema, DTR is breast, plantar is extensor. No other rest other the systemic examination is normal. Due to the poor GCS, child is shifted on the ventilatory support for airway protection. Neuroimaging shows the communicating hydrocephalus with periventricular ooze with extensive basal exudate. CSF examination also shows lymphocytic predominant, protein is more than 1 gram, CSF sugar level is low, NAT in the NAT early detected MTB bacteriologically confirmation with rifampicin sensitive. So due course of the time, child is shifted to PICU and managed by the ATT and steroids. Later, the repeat neuroimaging shows arterial infarct, so antiplatelet aspirin is added in this case. Due course of the time, child has clinically worsening in the form of the dystonia, hyponatremia, dilutional hyponatremia with oligo, with that was suspected SIADS. So child is managed with fluid restrictions and anti-dystonic medicines was given. The child is also having the hydrocephalus, which was managed by the 3% NaCl, and external ventricular drain was also surgically inserted. During the extubation, child developed the laryngeal dystonia. So the tracheostomy tube was inserted and child was successfully discharged with the ATT, anti-TB steroids and aspirin at the GCS of E4, BT and M5. So this is the summary of that.
Thank you. I hope with this most of our doubts are clear, and we will be closing today's session. I will request all of you to please fill the post-test questionnaire through the link that has been shared in the chat box. So with this, we come to the end of today's session. But before I close, I would like to thank the team from AIIMS Raipur for this interesting case discussion. And I would also like to especially thank Dr. S.K. Kabra, Consultant Pediatrics at Apollo Hospital, for accepting our invitation to be the national expert for today's session at a very short notice. Thank you, sir, for your guidance and encouragement. It was indeed enlightening for us to have you here today. I would now like to invite Dr. Ashok Bhardwaj, Chairman of the National Task Force, for his closing remarks.
So thank you, Dhulika. So first of all, I'll thank the team NITRD for sustaining this endeavor continuously. So then I want to thank team AIIMS Raipur, the Department of Pediatrics, for excellently presentation of this case, interesting case, and following the guidelines also. So I thank Dr. Kabra for his excellent comments on INH sensitivity or resistance for this case. I want to thank all the participants who participated. The number was at one time more than 120. So thank you very much. Thank you team for continuing this endeavor. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir. So we will all meet for the next TB Eco Clinic on the 3rd Tuesday next month, that is in August. See you then with an interesting case discussion again next month.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Thank you, ma'am. Thank you.
We'll keep the session running for 2 minutes so that those who have not filled the post-test questionnaire can continue to do that. Thank you.